Okay. So in this talk, I will try to talk about the fundamental role of sensory reactivity in ASD. The pain, I'll talk about the pain perception in ASD, and sensory overreactivity as a factor in the pain perception. Okay. After watching this clip, it is pretty easy to get this model, which was developed by Wallace, claiming that the sensory and multisensory perceptions are the cornerstones for socialization and communication development. In fact, they suggest this model as one that explains the development of ASD core symptoms, the atypical socialization and communication. Reports point at very high incidence of sensory reactivity alterations in ASD, at least 70%. But maybe more significantly, these were found associated with ASD symptom severity, challenging behavior including self-injury, and restricted participation in daily life. The neurophysiological excitatory-inhibitory imbalance is one of the mechanisms suggested to underlie autism, leading to increased connectivity between different brain areas, and is related to core clinical symptoms in ASD and may also cause sensory overreactivity. On your right, there is a flowchart created by Kimberly and Bonito showing the trajectory from increased connectivity in auditory processing brain areas. Sorry. מה לעשות? טוב. Sorry. So again, this is showing the trajectory from increased connectivity in auditory processing brain areas to the clinical manifestation of a child covering his ears to avoid noise, which impact social interaction. And indeed, brain imaging and EEG recordings confirm that not only that there is increased connectivity in ASD in response to aversive auditory and visual stimuli in different areas on your left, but the brain activity was correlated to the reported sensory overreactivity. So finally, the sensory realm was added to the DSM criteria for diagnosing ASD. Interestingly, the DSM points at pain, which is a sensory system, so that's okay, but using the example of being indifferent to pain. So let's look at pain in ASD, which only recently started to gain empirical attention. So the literature states that the widely held belief is that ASD people are hyposensitive to pain because of the high percentage of self-injurious behavior, in line with the example that I just showed you in the DSM. While a review by Aleli, she concluded that individuals with ASD may be hypersensitive to pain, while Moore, 1 year later, in his review, he concluded that ASD individuals are not different than typical individuals. And this actually, I think, expresses the controversy in the understanding of the pain perception in ASD. This inconsistency is evident in also experimental pain studies. On your left, finding point at reduced pain threshold, meaning higher pain sensitivity, when on your right, the opposite was found. But a more closer link to real life can be seen in this observational study during venipuncture by Turgeman. 55% of ASD children were classified by medical staff as showing absent or hyporeactive responses to pain, versus only 39 in the typical children, Moreover, a high proportion of children with ASD engage in self-injurious behavior right after this procedure, versus none in the control group. Endorphin plasma levels, were higher in the ASD group in general compared to the control, and even higher within the ASD group in the more severe ASD in compared to the less severe ASD, and this you can see on your right. Taken together, the findings were viewed as evidence that individuals with ASD may feel pain, but may not always show pain in the same way as others. Ratas, who also observed responsiveness to venipuncture, sadly, I think, stated that although the typical population were routinely given anesthesia before this procedure, venipuncture in children, in the ASD population, this figure was less than 50%. The notion that the ASD maybe show pain differently may be supported by the following study, where fMRI results indicated that both groups, control and ASD, showed a similar initial neural response to heat-induced pain. However, adults with ASD showed a reduced response to prolonged painful stimulation compared to control, a finding that investigators speculated may reflect different strategies for coping with pain. So if I sum, communication difficulties, assuming not feeling pain, self-injury in 50% of autistic people, which is associated with pain, along with an unsuitable pain assessment, can actually lead to overlooking pain and neglecting pain treatment. And sure enough, the American Academy of Pediatrics came out with guidelines, I think about 2 years ago, for treating pain in severe neurological impairment, but stated very clearly that though pain may be related to self-injurious behavior in ASD, this report is not specific to autism because pain in this group has not been well studied. This could have crucial consequences because untreated pain can cause plastic changes in the central pain system, amplifying pain sensitivity, and may possibly lead to pain chronicity and suffering. So based on the ASD heterogeneity and on our previous research in pain and sensory overreactivity in healthy people, we were thinking that sensory overreactivity may be a potential factor explaining the inconsistency in the reported pain perception finding that I just went over now. Specifically, investigating children and adults that are healthy, otherwise healthy, we previously found in experimental pain setting using psychophysical approach in the lab that those with sensory overreactivity in red rated pain higher and the pain lasted longer. The lingering sensation the two figures on your right was tested over 6 minutes. Over 6 minutes after termination of the stimuli, So both of these markers are excitatory signs, which brought us to propose the SM-Dolor model explaining the pain in sensory overreactivity, which we suggest that the EI imbalance, the excitatory-inhibitory imbalance, underlies the amplified responses to non-painful stimuli and painful stimuli that we see and people with sensory overreactivity report. And this model served as the theoretical foundation for exploring pain in autism. So we set a multi-method design to explore the pain perception in high-functioning adults with ASD. The study is still going on. So today I will present some psychophysical findings. Our goal So to make it very clear, our goal is to test whether subgrouping of the ASD group to those with versus those without sensory overreactivity will shed light on the pain perception controversy. This is what we're aiming to. Okay, so now to our findings. We begin with testing, first of all, the pain thresholds. So we tested pain thresholds to heat pain. On your left, when comparing the two groups, ASD in red, neurotypical in blue, we found no differences in pain thresholds like other report before us reported. However, when dividing the ASDs to with SOR, with sensory overreactivity versus without sensory overreactivity, we found group differences. Specifically, those with ASD who also have sensory overreactivity showed lower pain thresholds, meaning more sensitive to pain. And also please note that we found 38% of the ASD people here that had also sensory overreactivity. Now I'll show you some tests that test super thresholds from various somatosensory modalities. So testing super thresholds, subjects were required to immerse their hand into hot water bath. We were seeking an individually tailored temperature that elicited a score of 40 in a 0 to 100 numerical pain scale. So it was individual tailored temperature, okay? So though, on your left, though the ASD reached a lower temperature on your left, after 1 minute, they rated the pain higher, and this you see on your right, showing pain amplification. Now, testing pain ratings to phasic thermal heat stimuli, we found once again pain amplification in the ASD group, but this time with no impact to whether you are or not with sensory overreactivity. Testing pain ratings to mechanical pinprick stimuli showed once again on your left that the ASD group rated the stimuli as more painful, while on your right, testing the subgroups within the ASD show that those with sensory overreactivity report higher pain ratings, while the ASDs with no SOR rated it lower. Okay, אני גומרת. Testing central sensitization via temporal summation shows on your left and after a while on your center, like after 10 times stimuli, that ASD groups starts with higher pain ratings and do not build up their temporal summation, contrary to neurotypical who demonstrate the physiological pain buildup. However, now testing the pain modulation via inhibitory capability found no group differences, though meaning the ASD are performing like the neurotypical, but we should remember that the inhibitory may be more robust with ASD because they start higher. They feel it more pain. They feel more pain. So if we sum, pain psychophysic yields pain hypersensitivity termed hyperalgesia in ASD, yet subgrouping sharpens this observation by showing that ASD who also are sensory overreactive rate their pain higher than ASD with no sensory alteration to some but not all painful stimuli or sensation. So to conclude, pain sensitivity varies in the ASD population. For sure, not all are indifferent to pain. The pain profiles varies over submodalities, which makes it a little complicated. Pain sensitivity is related to sensory overreactivity in ASD, and subgrouping the ASD population based on sensory overreactivity may help understand the individual's pain experience. And is pain sensitivity also related to the clinical manifestation of ASD and whether there is a pain neurophysiological signature or whether this is related to the clinical manifestation, we still are not sure. But this study is continuing. And I want to thank you and my collaborators and students, and Einat Gal is here with us. Thank you.
We have time for a question, if someone wants to ask. One in the back.
Yeah.
Go ahead.
Tell us how you measure sensory overreactivity. That's not a trivial thing to assess.
We measure it with a self-report. In this case, they're all high functioning with IQ of 80 and above. So there is standardized measures.
Which one? Sensory profile.
There is sensory profile, and we're using the sensory responsiveness questionnaire, which gives you a cutoff whether you are or not with sensory modulation dysfunction.
Okay, thank you.